Good afternoon, ladies and gentlemen. It's my great pleasure to welcome you to the webinar organized by the European Reference Kidney Network, coordinated by Franz Schäfer from Heidelberg, Germany. The topic of today is membranous nephropathy, and it will be presented by Professor Jacques Wetzels from Nijmegen, the Netherlands. I am Elena Levchenko, I'm a pediatric nephrologist from Belgium, and I will moderate this webinar from my office in Leuven, Belgium. So that during the webinars, the slides will be projected on your screen, and you can send us questions. You should not wait until the end of the webinar. You can send questions at any moment during the presentations using your attendee panel. The webinar will be recorded and the slides will be published at the website of the ERKNet. At the end of the webinar, we will have some questions to you, so please listen attentively so that you will be able to answer all questions. Let me now introduce our speaker of today, Professor Jacques Wetzels from Nijmegen, the Netherlands. Jacques has studied medicine in the University of Nijmegen. He was trained in internal medicine in nephrology in the same Radboud University, where he received his PhD in 1989. From 1990 to 1992, he studied ischemic renal tubular injury as a postdoctoral fellow under supervision of Robert Schneier in the University of Colorado Health Science Center in Denver, in the USA. And since 1992, he is working as a nephrologist in the Netherlands. And in 2002, he was appointed as a professor of nephrology in the Department of Nephrology at Radboud University, Nijmegen. As chair, he is committed to teaching and research, and membranous nephropathy is one of his research topics for which he is recognized worldwide. So I think after this introduction, I give the word to Professor Wetzels, and he will start his lecture now. Please, Jacques.
Thank you, Elena, for this introduction. Ladies and gentlemen, welcome. And this talk will be on membranous nephropathy. As you all know, membranous nephropathy is the most common cause of the nephrotic syndrome. The incidence is 10 per million per year, and we differentiate between secondary and primary membranous nephropathy, where the secondary forms are based on cancer, systemic diseases, or the use of certain drugs, whereas in primary membranous nephropathy there is no underlying cause. The characteristic findings of membranous nephropathy is the presence of immune complexes containing IgG and C3, which are localized in the subepithelial space, as you see in this EM picture. The natural history of membranous nephropathy has remained unchanged over the last decades. Most textbooks often quote the rule of thirds, meaning that after a certain time of follow-up, 1/3 of the patients will have developed spontaneous remission, 1/3 of the patients will have progressed to renal insufficiency, and 1/3 of the patients will have persistent nephrotic syndrome. However, as you see in this picture, if you have prolonged follow-up, then this rule of thirds changes to a rule of halves, meaning that after 5 years of follow-up, actually almost half of the patients have progressed to end-stage renal disease, and 40 to 50% of the patients have reached partial or complete spontaneous remission. In the end, few patients have persistent nephrotic syndrome. The treatment of membranous nephropathy in the past has been based on the use of alkylating agents, and these drugs have been proven effective in reducing the incidence of end-stage renal disease in 2 randomized controlled trials published in 1995 and 2007. In 2009, there has been a major change in patient care and research based on the finding that in the serum of patients with membranous nephropathy, antibodies directed against the phospholipase A2 receptor could be detected. And it's now clear that more than 80% of patients with primary membranous nephropathy have a PLA2R receptor-related disease, meaning that in more than 80% of patients with membranous nephropathy, antibodies against the phospholipase A2 receptor can be found. This receptor is a protein which is present on the podocyte membrane. In the KDIGO guidelines that were published in 2012, the management of patients with membranous nephropathy was as follows in this simplified scheme. We do a kidney biopsy to diagnose membranous nephropathy. Then we try to define high-risk patients based on the presence of proteinuria of more than 4 grams per day for more than 6 months. And in these high-risk patients, we try to limit the development of end-stage renal disease by treating with immunosuppressive agents, using alkylating agents, or calcineurin inhibitors. In this talk, over the next 20 minutes, I will discuss some recent advantages, trying to describe to you the possibilities of more individualized patient care. And I will address the following topics: the diagnosis of membranous nephropathy, the prognosis, the outcome, and the treatment. With respect to diagnosis, this slide presents to you an overview of a large meta-analysis, and actually what is shown here that the specificity to diagnose membranous nephropathy when antibodies against PLA2R are present in the serum, the specificity is 0.99 with a confidence interval of 0.96 to 1, meaning that if antibodies are present in the serum, you have a very high likelihood that the diagnosis is membranous nephropathy, and the false positive rate is only 1%. This means that for the diagnosis of membranous nephropathy, we can omit the kidney biopsy, and we can now go to a serological diagnosis of membranous nephropathy, meaning that if a patient presents with a nephrotic syndrome, we can measure the PLA2R antibodies. If the antibodies are negative, obviously we will have to do a kidney biopsy. If the antibodies are positive and the patient is considered at low risk of disease progression, we do not do a biopsy and have a wait-and-see policy. There is debate and discussion on the necessity to perform a kidney biopsy in high-risk patients, and there are certain reasons to still do a biopsy in patients with a low GFR, in patients with acute kidney injury, and in patients who are going to use immunosuppressive therapy with toxic regimens containing cyclophosphamide. Still, even in this high-risk category, if the biopsy is not without risks, then you can consider to omit a kidney biopsy. If we are talking about the serological diagnosis, it's important to realize that there are differences between the various assays. This slide shows you the 4 assays which are available. The oldest technique was the Western blot technique, the way Beck and co-workers detected the PLA2R antibodies in the serum. A new commercial available technique is the immunofluorescence technique, based on measuring the immunofluorescence staining when applying serum to a dish coated with cultured cells which express the antigen. Then we have an ELISA technique, which allows you to do a quantitative assay, and there are new laser bead technologies which are currently under development. What is important to realize is that these assays differ in sensitivity, and these are examples of some recent studies comparing the diagnosis based on immunofluorescence and ELISA, or Western blot and immunofluorescence. And what this table shows you is that there are patients who are negative in ELISA and positive in immunofluorescence technique, and again here negative in ELISA, positive in the IFT, whereas the reverse, positive in ELISA and negative in the IFT, is a very rare event. Also, when you compare IFT and Western blot, then it's clear that there is a difference, that the IFT also is less sensitive than the Western blot. Overall, the ELISA technique is the least sensitive technique, which means that to diagnose PLA2R-associated membranous nephropathy, immunofluorescence techniques give you a better value. What also important is to realize that initially already it was shown by the work of Pierre Ronco that there are many patients who are positive with the biopsy and negative in the serum, meaning that patients with PLA2R-associated disease can have PLA2R-associated disease without the presence of antibodies in the serum. What important is to realize that this can happen especially in the early phase of the disease. And here I have one patient history of a patient who had PLA2R-associated disease based on positive PLA2R staining in the initial kidney biopsy. This patient was treated, but after a while there was a relapse of proteinuria here in 2013 with an increase of proteinuria and already the development of low serum albumin with nephrotic syndrome. In the beginning of this phase, the antibodies were not detectable, and only after a couple of months, 5 months, the antibodies became positive. And this suggests that in the beginning of PLA2R-associated disease, the antibodies can hide in the kidney, bind to the antigen, and only become present in the serum and measurable if all these binding places in the kidney are saturated. The next topic is on the prognosis of patients with membranous nephropathy. This graph, this table, is data from a randomized controlled trial, the Hemorrhagic study, which is a randomized controlled trial comparing rituximab with placebo. And here you have the remission rate in the patients treated with placebo. These patients all received non-immunosuppressive antiproteinuria therapy. And you can see that without immunosuppressive therapy, there is an increasing incidence of remissions, finally going to a value of 45% after an average follow-up of 23 months. In this study, patients were selected for treatment and were randomized after a waiting period of almost 6 months with a proteinuria of more than 4 grams per day, according to KDIGO recommendations. And thus clearly these data shows that the accuracy of these recommendations to select high-risk patients is low, below 60%. And it's important to try to find better prognostic markers, because patients who have a reasonable outcome and a spontaneous remission rate of 45%, these patients all receive immunosuppressive treatment unnecessarily. So we need better prognostic markers. This slide shows you the prognostic, the risk prediction by using urinary low molecular weight proteins like beta-2 microglobulin. And in this graph, it's clear that if you have an increased excretion of beta-2 microglobulin using a cutoff value of 0.5 micrograms per minute, then the likelihood urinal survival is bad and the likelihood of progression is more than 80%. Whereas if you have a low excretion of this low molecular weight protein, the risk of progression is below 20%. In a comparison, it became evident that the excretion of either urinary beta-2 microglobulin or urinary alpha-1 microglobulin has a similar accuracy as the so-called Toronto risk score, which is risk prediction based on a score which includes the urinary protein creatinine ratio, the baseline creatinine clearance, and the change in the creatinine clearance over a 6-month period. So both the Toronto risk score and the urine excretion of low molecular weight proteins allow better risk prediction, but still the accuracy is only 75%. Low molecular weight proteins could become more valuable if we do repeated measurements. And in this slide, we show baseline urinary excretion of low molecular weight protein and the excretion measured after 6 to 9 months. And from this slide, it is clear that if you have increased excretion of these low molecular weight proteins twice, then the risk of progression is very high. Whereas if the excretion is below a certain cutoff value twice, the risk of progression is very low. So by repeating the measurements after a period of 6 to 12 months, the accuracy of risk prediction becomes higher and amounts 90%. And obviously, we hope that validation of these studies will make sure that this risk prediction of 90% is true. Obviously, with the finding of antibodies in the serum of patients with membranous nephropathy, the question arose whether measuring these antibodies could help in risk prediction. And this slide summarizes 2 studies. One study showing what is the likelihood of a spontaneous remission based on the measurement of anti-PLA2R antibodies, and here grouping the patients in tertiles according to the antibody levels. And it's clear that if the antibodies were high, then the likelihood of a spontaneous remission was very low, whereas if the antibody titer was low, the likelihood of a spontaneous remission was much better. In another study from the Paris group, it was also shown that measuring the PLA2R antibody titer using the commercially available ELISA also allows a certain risk prediction. If you have an increased level, a high level above 275 units per ml, then the likelihood of developing a spontaneous remission after 17 months was 20%, whereas if the antibody titers were below the cutoff level, then the likelihood of developing spontaneous remission was higher at 43%. Still, if you look at these data and these data, it's very clear that the sensitivity and specificity of these cutoff values to predict the risk is much lower than 80%. So at this time, the antibodies do not allow better risk prediction. Obviously, we need to have studies where these various biomarkers are combined to see if we can develop a model whereby combining the PLA2R antibody levels, the urine low molecular weight proteins, the duration of proteinuria, and the serum creatinine value, if we can combine these values to a score and define higher risk with a higher likelihood. Still, by using this information right now, we can predict the risk with an accuracy of at least 80%. If we predict high risk, we can consider immunosuppressive treatment. If the risk is low, we would advocate a wait-and-see policy. Obviously, when waiting and not using immunosuppressive therapy, we need to be aware that patients with nephrotic syndrome are at risk for arterial and venous thromboembolic events. And this is something which is especially true in patients with membranous nephropathy, where the risk of thrombosis is higher than in patients with FSGS or IgA nephropathy. And also, it's important to realize that the risk is based and related to the serum albumin level. Based on this increased risk, algorithms have developed which try to define how to treat these patients. And this is an algorithm that can be used where based on the serum albumin value, the risk of venous and arterial thrombosis is estimated, and then by adding a risk of bleeding score, which can be found on the internet, it's possible to balance the advantage of prophylactic treatment against the risk of bleeding. And then if the bleeding risk is low and the thrombosis risk is high, the guidelines advocate the use of warfarin. If the bleeding risk is high or the risk is relatively low, then it's a possibility to use a score looking at arterial thrombosis risk, and then these patients should be treated with aspirin. If serum albumin values are high, above 3 or 3.2 grams per deciliter, then there is no reason to treat at all. When considering this anticoagulant treatment in patients with primary membranous nephropathy, it's important to realize that there is no proof that warfarin is better than in combination of a prophylactic dose of low molecular weight heparin and acetylsalicylic acid combined. So this is also a useful combination. It's important to realize that the new developed drugs, the DOACs, are not tested in patients with a nephrotic syndrome, and there are recent studies suggesting that the metabolism and the kinetics of these drugs are different in patients with a nephrotic syndrome, and that thrombosis can develop even when these patients are treated with such kind of drugs. So for now, we advise not to use these drugs in patients with severe nephrotic syndrome. And the third important point is that we should be aware that there is no standardization of the serum albumin assay, meaning that in different hospitals, different assays are used which give a different value of serum albumin. And if we use certain cutoff values, it's important to realize and to understand what is the assay used in your hospital. In brief, there are three important techniques now in use: the immunonephrolometric method, and then two colorimetric assays, Brom-Kazole purple, BCP, and Brom-Kazole green, BCG. And I summarize this by saying that the BCP gives you the same value as the immunonephrolometric albumin assay, which is a golden standard, I think. And the BCG assay overestimates the serum albumin value by 5 grams per liter, meaning that a value of 20 grams per liter with the BCP assay gives you a value of 25 grams per liter with the BCG assay. And if you use cutoff values of 20 or 25 grams per liter to define nephrotic syndrome or to start anticoagulant treatment, you need to be aware what is the technique used in your hospital. Now I go to the treatment of patients with membranous nephropathy. As stated in my introduction, alkylating agents are effective and proven in randomized controlled trials on hard renal endpoints like end-stage renal disease. Obviously, the use of alkylating agents is associated with side effects, both short-term and long-term. And especially in the long term, the most feared side effects is the incidence of malignancy, which is almost 3-fold higher after 10 years of follow-up. So there are two important questions. One, can we restrict treatment to high-risk patients, meaning that if we delay treatment and only treat the 50 to 60% patients at highest risk, do we get a good long-term outcome? And the second question is, can we use alternative agents? This slide shows you that restrictive treatment is very effective. And this is an overview of a protocol where treatment was restricted to high-risk patients, and after a follow-up in 254 patients, then it became clear that almost half of these patients had received immunosuppressive therapy, but the other half had only been treated with supportive treatment. And after a follow-up of on average 5 years, then the outcome was reasonably good, and the 10-year dialysis-free survival was 86%, which is comparable to the survival range found in the randomized controlled trials, where all patients with membranous nephropathy and nephrotic syndrome were treated. So we can restrict treatment and only use the treatment in the highest risk category. Obviously, this treatment is associated with the high risk of malignancy, as I already told before, a threefold risk compared to a control population. So what about alternative agents? One alternative would be the calcineurin inhibitors. And indeed, it is shown that these drugs induce remission. However, the use of calcineurin inhibitors is associated with a high relapse rate, approximately 75% or higher, and relapses are associated with the risk of end-stage renal disease. So actually, we need more data on long-term follow-up of the use of calcineurin inhibitors, especially looking at hard renal endpoints such as end-stage renal disease. There are currently two studies. One is under review and the other is still running and will be reported next year, hopefully. And these studies, the Mentor study, compared the use of rituximab with calcineurin inhibitor cyclosporin, and the Starman trial is comparing cyclophosphamide with a combination of tacrolimus and rituximab. And the first data of the Mentor study, which were presented last year at ASN, showed that the recurrence rate was very high with using cyclosporin, and that rituximab induced remission, which were at least persistent for a longer period of approximately 12 to 18 months after the last dose of rituximab. Long follow-up is not available yet. We know from Italian studies that rituximab induces a higher remission rate. And in France, very recently, we had the report of the first randomized control trial with rituximab. And this was a trial comparing rituximab with no treatment. Both groups received maximal non-immunosuppressive anti-proteinuria treatment targeting proteinuria, blood pressure, cholesterol, and so on. And this study showed that in the initial 6-month period, there was no significant difference in the remission rate. However, after prolonged follow-up, there was a significant difference and a higher remission rate obtained with rituximab. So clearly, this study showed that rituximab is more effective than placebo in inducing remissions. What is also important in this study is that even after long follow-up, the remission rate with rituximab is only 66%, and that's actually a general feature of all rituximab studies. If you look at the primary non-response rate, then the non-response rate varies between 22 to 35%, meaning that a certain percentage of patients do not respond with a remission to the treatment with the current doses of rituximab. We compared rituximab and cyclophosphamide by using data from the Bergamo group and using data from our group to try to find out what could be differences between these drugs. So this is non-randomized controlled trial. This is a comparison of two cohorts of treated patients, but we try to adjust for differences in baseline value. And this slide shows you the adverse events and the serious adverse events, and not unexpectedly, the use of cyclophosphamide is associated with more adverse events. However, looking at the final outcome, there was no difference in complete remission rate, but there is a difference in partial remission rate, with the rituximab-treated patient clearly having a lower rate of partial remissions than the cyclophosphamide-treated patients, suggesting that there indeed might be a difference and that resistance to rituximab may be more frequently than resistance to cyclophosphamide. And this was also suggested in a comparison where we looked at the immunological response, so the disappearance of the antibodies in patients treated with cyclophosphamide and in patients treated with rituximab. And in this slide, patients were grouped according to the level of the phospholipase A2 antibodies, going from low to high, comparing cyclophosphamide and rituximab. And what is evident in this slide is that patients who received cyclophosphamide responded independent of the baseline antibody levels. This was different in the rituximab-treated patients. In patients with very high antibody levels, the response to rituximab was less, meaning that almost no patient developed an immunological remission with rituximab if they had high baseline levels of anti-phospholipase A2 antibodies. And this actually confirmed another investigation already done by the Italian investigator, showing that if you use rituximab and you look at the baseline levels of anti-PLA2R antibodies, then patients in the highest tertile of antibodies had I would say, a limited response to rituximab, only 1/3 of patients developing a remission of proteinuria. So this again shows that high antibody levels predict a worse response to rituximab. And based on these data, we suggest that in future the treatment algorithm could change, that in a patient with nephrotic syndrome, you could diagnose membranous nephropathy, either by biopsy of using the PLA2R antibodies, by measuring the antibodies, looking at the level of the antibodies, looking at urine low medical weight proteins, looking at the level and duration of proteinuria, and looking at serum creatinine or creatinine clearance, you could predict the risk. If the risk is estimated below, you can wait and see. When necessary, treat the patient with anticoagulant drug and then wait until the patients develop a spontaneous remission, which can take 2 to 3 years. If the patient is considered to be at high risk for disease progression, then you could imagine that if the antibody titers are low, you could try treatment with rituximab or calcineurin inhibitor as first choice. If the antibody titers are high, and especially if the serum creatinine is already a little bit increased, then cyclophosphamide still would be the first choice of treatment. Obviously, this is not a guideline, because this needs to be based on more firm evidence, but this could be a realistic view on how to individualize the treatment of patients with membranous nephropathy. But also I think is important that if you treat patients with membranous nephropathy with immunosuppressive drugs and you have the possibility to measure anti-phospholipase A2 antibodies, it's important to monitor the treatment. And this slide shows that if you monitor the treatment and you look at the outcome of patients where the antibodies have not disappeared after treatment, then in fact the outcome is bad and none of these patients will develop a persistent remission. The alternative, if the antibodies have disappeared, you have a longer period of remission, although some patients will have a relapse and need treatment again. Still, I think it's very important to realize that if the antibodies have not disappeared at the end of your treatment, whatever the treatment you choose, then you should think about adding a new treatment because the first treatment is not likely to allow patients to develop a remission of proteinuria. So the first conclusions of this session, I think that individualized treatment of patients with membranous nephropathy is coming soon. If you are able to measure antibodies, then you might consider to not do a kidney biopsy for the diagnosis of membranous nephropathy. If you use an assay, be aware that there are differences, and to diagnose membranous nephropathy, the ELISA assay is least sensitive, so you better can use an immunofluorescence test. For the prediction of prognosis, we have various biomarkers, and in future studies, we should try to find out whether we can combine these biomarkers to find an optimal score. But with the currently available biomarkers, you should be able to predict the risk with at least 80% of accuracy. It's important to consider thrombosis prophylaxis in a patient, looking at the individual risk of the patient, his serum albumin values, and also looking at the bleeding risk, which you can find at the internet. When evaluating risk of thrombosis, be aware of differences in the albumin assays. It's important to realize that cyclophosphamide is effective and can be restricted, should be restricted to high-risk patients. Rituximab and CNI are drugs which are able to induce an remission and could be beneficial in the patients at moderate risk of disease progression, but patients with very high antibody titers and patients with progressive renal insufficiency do not respond to rituximab at the standard dose and will most likely be dependent on the use of cyclophosphamide. And importantly, measure antibody levels to guide the treatment. Future studies will find out whether measurement of epitope spreading, so looking at differences between the antibodies in the serum, is important. At this moment, this is not clear yet and cannot be implemented in our patient care at current time. And also, there are details on new genes or the interaction, the relation between some genes and prognosis and outcome in patients with membranous nephropathy. And although interesting at this time point, it's not available for use in the clinic. So with this, I end my session, and we will start by asking you some questions.
Okay, thank you very much. I think, Jacques, maybe you just read the questions and people can vote. You will have 30 seconds to vote, so just go on soon.
Okay, let's see. Yeah, I cannot see the question in the poll, so I have to go to my slides again.
Okay, so maybe just go on.
So the first question is if PLA2R antibodies can be absent in patients with PLA2R associated membranous nephropathy, and you can now answer the question yes or no.
Okay, Jacques, can you see the answers or not?
No, my thing, I don't see the answer, so you have to.
Okay, so I will have to moderate it. So 91% of patients have answered yes.
Okay. Yeah, so the right answer is indeed yes. As I showed, is that in some patients, especially in the initial phase of the disease, you can have antibodies which are hidden in the kidney biopsy. And that's important because if you are able to stain the kidney biopsy for PLA2R antigen, you already can have the impression that it's PLA2R associated disease. If you don't have the possibility to stain the biopsy for the antigen, I would simply advise in patients who present with nephrotic syndrome who are negative to repeat the measurement after 4 to 6 months, because if they have PLA2R antibodies, there is a good likelihood that at that time they will be present in the serum.
Okay, so we can go on to the next question.
Okay. So the next question is, which assay is the least sensitive to detect the antibodies? And there are 3 options: the ELISA assay, the immunofluorescence test, or the Western blot.
Okay, please vote. So the answers are ELISA, so 73%, immunofluorescence 7%, Western blot 20%.
Yeah, so the right answer is the ELISA test. I would say that the Western blot assay is most sensitive, then the immunofluorescence test, and the ELISA is least sensitive, meaning that if you do an ELISA test, that you can miss some patients with PLA2R associated disease. And if you want to avoid the need for a kidney biopsy, the best thing would be to use the most sensitive test. Unfortunately, the Western blot is not commercially available, so for standard laboratories, we need to rely on the immunofluorescence test.
Okay, next question, please.
Okay. The next question is that serum albumin is an important parameter in nephrology, and the question regards the use of different assays, and the question is, what is the right answer? The BC, the Brome-Cresol green assay, but not the Brome-Cresol purple assay, overestimates serum albumin. The alternative, the Brome-Cresol purple, but not the Brome-Cresol green, overestimates serum albumin, or both BCP and BCG overestimate serum albumin.
Okay, please vote.
Okay. I would have liked to ask the question if the participants know which assay is used in the laboratory, but my experience in our country is that almost none of the physicians actually know which assays are used by the lab.
Okay, so the answers are A is 67%, B 13%, and C 21%.
Yeah. So the right answer is A, because the Brome-Cresol green assay is the assay which provides you a serum albumin value which is 5 grams per liter higher than when measured with either the BCP or the immunonephropatic assay.
Okay, next question.
Okay. So the next question is oh, I hear myself. But the next question is on the anticoagulant treatment in patients with a nephrotic syndrome. And the question is, what would be the right choice for the treatment of patients with low serum albumin? And the possibilities are combination of acetyl salicylic acid and warfarin. The second alternative is the use of apixaban. The third alternative is low molecular weight heparin in a prophylactic dose. And the fourth alternative is the use of warfarin.
Okay, people can vote. Okay, I give you the answers are A 39%, B 0, C 10, D 7, E 44.
Okay, I thought there were only four alternatives. The right answer would be warfarin. Low molecular weight heparin in a prophylactic dose would not be sufficient to overcome the arterial thromboembolic events. Apixaban, I think, is important to realize that there are no data to use these drugs in nephrotic syndrome, and so we are very reluctant. And the combination of warfarin with acetyl salicylic acid is too much, so there's no need for double therapy. So warfarin would be the best alternative, and another alternative, which is not in the answers, could be a prophylactic dose of low molecular weight heparin combined with acetyl salicylic acid.
Okay, thank you very much. Next question. In the meantime, the audience can ask the questions. I will see your questions and we can ask them after this voting session. Okay, so the question is on...
The next question is, high PLA2R antibody titers predict non-response to rituximab, and the alternatives are no or yes.
Okay, so the answer is yes, 75%, no, 25%.
Yeah, so for now, I think that with the currently used dose of rituximab, it is clear that high PLA2R antibody levels suggest that the response will be very bad. Okay.
Okay, so this was the majority answered correctly. So the next question is now on the screen.
Okay, so the last question is that the likelihood of a spontaneous remission in patients with nephrotic syndrome and membranous nephropathy is 10, 20, 30, or 40%.
Okay, this should be an easy one.
I think so, but it's the last, so.
Yeah. Okay, excellent. So 10%, so A was answered by 5%, B 12%, C by 34%, and 40% by 49%. So there, the majority was right, I think.
Okay, yeah. I think it's important to realize that there's a large high incidence of spontaneous remission, so we need to be a little bit reluctant with very early treatment with immunosuppressive therapy.
Okay, thank you very much. So that was the last question to the audience. Now we still have time for the questions from the audience. And the first question, I have to look whether I can read it well. Olivier Boyer mentioned that they could not vote for all options, but I think, yeah, sorry for that. Okay, more questions or comments from the audience? I have a question from a person who didn't want to identify him or herself. So the question is, why low molecular proteins like beta-2 microglobulin predict the outcome? Due to the fact that they represent tubular proteinuria rather than glomerular damage?
Yeah, I think what we think is that if you have glomerular damage, then in the initial phase you have reversible injury. But if you have a serious injury to your glomerular capillary wall, high levels of proteinuria, you will have progressive disease, and progressive disease is characterized by the development of tubular interstitial injury and tubular interstitial atrophy and fibrosis, and that's characterized by and represented by the increased excretion of low molecular proteins. So actually, probably we are seeing processes which are developing, and we know already for a very long time that the deterioration of renal function is best reflected by processes which are occurring in the tubular interstitium.
Okay, thank you very much. While people are thinking about the next question, maybe I can ask you the question, what happens with PLA2R antibodies in patients who undergo the spontaneous remission? Do these antibodies disappear completely, or they keep low titer of these antibodies?
I would say in the large majority of the patients, the antibodies disappear, and actually if you develop spontaneous remission, but also if you develop remission after treatment, then the normal disease course is that you first see that the antibodies disappear, and then after 3 to 12 months, the proteinuria disappears. There are very rare patients that I have seen where antibodies have persisted even in the phase of remission, and I would say we have to sort out whether these, the antigenic epitopes of these antibodies are special. But in general, in routine daily care, you should find that the antibodies disappear, and they disappear before you have a remission of proteinuria.
Okay, thank you very much. There is another question about screening for malignancy. So the question is, should we stop screening for malignancies in patients with high PLA2R antibody titers? Does it completely exclude malignancy, and we just not screen for that?
Yeah. So this is a question which actually is not answered right now. I think that the guidelines and also the new guidelines will suggest that even in patients with antibodies, we should be aware of malignancies. However, the intensity of screening, I think, could be reasonably limited. In our hospital, we are used to just do laboratory investigation to look for anemia and liver dysfunction. We do an X-ray of the thorax, but that's especially also to see whether there is sarcoidosis, because that's associated even with PLA2R associated membranous nephropathy. And we ask whether the patients have gone to the regular cancer screening, which is present in the country, but we do not do other investigations. Personally, I think that the chance of a malignancy in a patient with PLA2R associated membranous nephropathy is not higher than in the general population, but even in the general population you can find a malignancy. And most of the patients with a malignancy described in association with PLA2R associated membranous nephropathy, I think this association is just by chance, but obviously that's very difficult to prove.
Okay, so we have your questions of asked by pediatricians, and actually the questions concerns the screening and the presence of PLA2R antibodies in children.
Yeah, so I'm aware that in children the prevalence or the incidence of antibodies against PLA2R in children is less. I think that it's important to realize that in children the epidemiology of membranous nephropathy might be different. You have very young children where there is an association between membranous nephropathy and antibodies against bovine serum albumin. Whereas I would say in children above 12 years of age, they are more likely to follow the pattern in adults. So in very young children, you will be less likely to find PLA2R antibodies. In children above 12 years of age, I would suggest to measure these antibodies also.
Okay, so now we have a question from Naveen Kumar. Is it possible to have PLA2R antibody positive membranous nephropathy and in SLE?
I would say that the most data that are there suggest that patients with lupus nephritis and membranous nephropathy do not have PLA2R antibodies. I'm aware of a Chinese report suggesting that it would be possible to find these patients, but yeah, I think the likelihood is very low. So normally, if a patient has lupus nephritis and a membranous pattern on the kidney biopsy, I don't measure PLA2R.
Okay, thank you very much. And there is another question asked by Dr. Davido Stellato. The question is, do PLA2R antibody exclude secondary causes of membranous nephropathy?
No, definitely not. There is a clear association between membranous nephropathy and sarcoidosis, and it has been shown that many patients with sarcoidosis and membranous nephropathy also have PLA2R antibodies, and the reason for that is unclear, but it's a known association. And there are some studies suggesting that in patients with hepatitis B, and maybe C, but especially hepatitis B, you also can have PLA2R associated membranous nephropathy. So I think that if patients have membranous nephropathy and are positive for PLA2R antibodies, it's especially important to look for sarcoidosis, and that's why we do the X-ray of the thorax. And also it's important to screen for hepatitis viruses, and I think that's done anyway, because if you consider immunosuppressive therapy, you need to know whether these patients are positive for hepatitis B or C.
Okay, thank you very much. We are not done yet. We have another question asked by Dr. Matteo Piemontese. The question is about membranous nephropathy in a pregnant woman. Which treatment would you recommend?
Well, that's a difficult question, because if you have a pregnant woman, then obviously the first choice would be to try to estimate the risk, and if the risk of progressive disease is low, then the the first trial would be to see if conservative management is working. Meaning that yeah, diuretic treatment and trying to keep the blood pressure normal would be the first step. But I can imagine that if the nephrotic syndrome is severe, then during pregnancy it will be almost untreatable. Then you would have a reason to treat. And I think then there are two possibilities. If the kidney function is normal, I think you could try a first course with tacrolimus, because tacrolimus, we know that it can induce remission, and although it's not the perfect treatment to maintain remission, it could be sufficient to carry on during pregnancy. And if, sorry, if the baby is delivered, you can go to another treatment. If the patient has deteriorating renal function, that option becomes a little bit difficult because tacrolimus will cause more severe renal failure. So in that case, you should, I think, try to start a combination with prednisone and low-dose tacrolimus or prednisone monotherapy. But the efficacy is dependent on the risk of the renal function. If there is severe renal insufficiency developing, I think there is no treatment which will be suitable in pregnancy, because the only one would be cyclophosphamide. And you could think about cyclophosphamide using it in the last trimester. But yeah, that would be a very difficult situation. And in practice, I think, I've never seen it, but in practice, I think that the outcome of such a pregnancy, if the kidney function rapidly deteriorates, is very bad. So maybe, you know, you should try to end the pregnancy at 30 or 32 weeks as soon as possible.
Thank you very much. I think we'll have now the last question. And this is regarding the recurrent membranous nephropathy post-kidney transplantation. Is it related to anti-PLA2 or a level before transplantation?
Well, I would say it's not, we don't have a perfect prediction. It's clear that if you have antibody present before transplantation, the risk of recurrence is higher than if the antibodies have disappeared. But there have been patients described with antibodies who did not develop recurrence. It's advised that if the patients have antibodies, that during follow-up you should be very careful to look for proteinuria, and if they develop proteinuria, do a kidney biopsy to see if there is a recurrence and start early treatment with rituximab. What is important also to realize that it is clear that if the antibodies are present and disappear, most people would be happy, but in the case of kidney transplantation, there have been patients described with antibodies present at the time of transplantation, where the antibodies disappeared while the patient developed proteinuria. And I think these cases reflect what I showed in my presentation, that these antibodies are first tightly bound to the glomerular basement membrane or to the podocytes. Taking up the antibodies will lead to disappearance of the antibodies for a while, and then you can have a recurrence with non-measurable antibodies, and still at that time you will detect it by doing the kidney biopsy. So I think, yes, measuring the antibodies is important and following the antibodies is important, but you cannot have a certain cutoff value to define whether there is a yes or no risk of disease. You can only estimate that the risk of recurrence will be higher if you have higher antibody titers, but it's not a very specific and sensitive measurement.
Okay, thank you very much. I think we will have to close the webinar, and I would like to thank Professor Wetzels for his wonderful talk and answering the questions, and the audience for being so active and asking so many questions. Thank you very much. The webinar is closed. Thank you.
Thank you very much. Bye-bye.
Bye-bye.